we're hosting Dr. Charles Ellis, who is professor and chair of the Department of Speech, Language, and Hearing Sciences at the University of Florida. He got his Ph.D. from University of Florida as well, but then branched out and spent time at MUSC, the Medical University of South Carolina, where some of our current colleagues also used to work here in South Carolina, and at East Carolina, and he's now back at the University of Florida. He is an ASHA fellow, as well as on the board of directors of the National Aphasia Association, and his research centers around outcomes associated with adult neurologically based disorders of communication and factors that contribute to the lack of equity in service provision and outcome disparities that exist among African Americans and other underrepresented minority groups. And today he'll be talking about the interrelationship between the social determinants of health and aphasia outcomes. Very pleased to have you here, Dr. Ellis. The floor is yours.
Yeah, thank you so much. And thank you for everyone who's on a Thursday afternoon. I know there are always many other options, so I'm really pleased that you're on. I think this is going to be a different kind of talk. I followed the C-STAR lecture series for several years now, and I know that it's clinically focused. And I think this research is going to take more of a health services approach, but I'll kind of start with the end in mind, is that the ideas and some of the research that I'm presenting here is not designed to argue against or take the place of a lot of the clinical research, because ultimately the issues of understanding outcomes lies in understanding how the nervous system works and how it is impacted in individuals with aphasia. But there seems to be some evidence that there may be some other factors that are in play that we might want to consider when we're trying to figure out optimal ways to manage people with aphasia and to achieve optimal outcomes. So here's kind of the gist of what I'd like to cover today is to define some key concepts in health disparities research, and to think about aphasia in kind of the context of what we know about health disparities, and explore some of the issues of social determinants of health, and then review two studies that we completed here, one that's published and then one that is under review. I'd like to get us thinking about some of the data and maybe even get any feedback. I think for anyone who's interested in this type of research, these are two books that I've read in the last couple of years, along with my long list of books that I was able to read during COVID. And one was The Health Gap, which offers some great insights into the multiple factors that contribute to health disparities, and takes more of a global look to help us look beyond just black-white differences, which is so often the case in the U.S. And then the second book by Daniel Dawes, who's at Morehouse in Atlanta, The Political Determinants of Health, I think is a very interesting book of where he goes back pre-Civil War to evaluate different decisions that the federal government has made, and how those decisions impact health, and how some of those decisions also marginalize different population groups. Because in our current political climate, and I don't want to get too much into politics, we can get so obsessed with insurance and the belief that ultimately drives the outcomes. But this book shows that it's far more than that, and it offers great details of even the Affordable Care Act, that ultimately it was drilled down to this issue of insurance and who deserves insurance, but that was never really the original intent. That sometimes an idea makes its way to Congress, and then there's a lot of negotiations as to what the final endpoint looks like. That bill was designed to reduce healthcare costs and improve equity and broader care, and it ultimately just became about insurance or no insurance. And so the primary focus, I believe, was lost in a lot of debates, and we're still at a point of trying to understand what was the impact, because we know that just offering people insurance will not solve some of these problems, because people can choose not to access care even if they have insurance. So it's not a simple solution. So just to kind of get us on the same page, where this issue of health disparities are just differences in health-related outcomes. And most of the literature says now that it's not just differences between population groups, but it's the way that people are born, grow, live, work, and age, or these social determinants. And a good way to think about it is, as a department chair, University of Florida, I have great insurance. I have great access to care, the same as University of South Carolina, but I didn't necessarily grow up that way, that I grew up in poverty. We didn't have insurance. We didn't go to the doctor on a regular basis. And my health outcomes as an adult are not simply the great care that I receive as an adult, but it's a combination of my lifespan and changes that occur even in early childhood, early in adulthood, that you're kind of the collection of all those time points, and that ultimately that dictates some of the longer term health outcomes. The second term, healthcare disparities, is a term to help us understand that there are differences in how population groups have access, experience, and receive healthcare. If you just think about the state of South Carolina, and Charleston, MUSC offers great care, and Columbia, USC offers great care, but there are still population groups in both of those cities that would never access care at either one of those hospitals from a historical perspective. And that was never made clear to me in the 9 years that I lived in Charleston, that there were people that lived right around the MUSC hospital that would not access care there because of the history. So again, back to this original point of insurance, insurance is not going to be the savior of health, because people have beliefs and attitudes about providers and systems and their own health that drive the decisions that they make. So when we're thinking about these issues of disparities, it's more than just the health disparities, but also the healthcare disparities related to issues like access and the quality of care. And then ultimately, what we're after is health equity. And that's the opportunity that everyone has to be as healthy as possible. That some folks will argue that, no, what I want is equality. Well, equality means that everyone gets the same thing. And when it comes to health, everyone doesn't need the same thing. They need what is ideal for them. And providers and systems and people are not always clear on that concept. And as such, we make decisions accordingly. So as we're thinking about this presentation and ultimately drilling this down to aphasia, these are some of the concepts that we definitely want to consider. I'd also like for us to think about this report from 2003, unequal treatment. It's just a reminder that health disparities are not new, that in 2001, 2002, under the Clinton administration, there was this idea that these disparities exist within the United States. And so the federal government commissioned the Institute of Medicine to evaluate healthcare in the United States. And basically what they found is that there were disparities found very consistently across different disease conditions, clinical services, private hospitals, public hospitals, VA hospitals, and that disparities in care were associated with higher mortality and morbidity among racial ethnic minorities. And so there didn't seem to be any clear explanation for why these disparities could exist across these wide-ranging systems and disease conditions. And as we have progressed in understanding disparities over the last 20 years, we've come to realize that it's far more than just race, that it's socioeconomic status, that regardless of race, poor people have worse health outcomes. There are disparities in things like stroke that are sex and gender differences, that women can have very different symptomology than men, and that they're less likely to receive evidence-based early medical care that ultimately impacts some of the outcomes that we see, that even among women, the issue of stroke is more than just women are older and experiencing stroke later in life, because when we look at younger stroke cohorts, we see some of the same issues. The spotlight on disparities came from COVID, and interestingly, it should not have been the shock that it was to the U.S., because when the early data from China emerged, it said very convincingly that if individuals had comorbid conditions, they were more likely to die. So if you considered kind of what we know about health and disease in the U.S., racial ethnic minorities, marginalized populations, people of color are more likely to have a multi-morbidity, and thus you would expect that there was going to be far greater risk of death and even in COVID, even though we knew very little about COVID at the time. And that's exactly how it ended up playing out, that the risk of death was 2 to 3 times greater, which aligns with what we see in stroke and diabetes, cardiovascular disease, that it pretty much aligned with those disease conditions. And so although there was a major focus on disparities issues and what are we going to do about this, it was not new. It was really just kind of the next disease condition that that the profile ended up showing the same type of risk and disparities. But sometimes bad news is good news. It sheds light on issues and it forces us to evaluate issues. So over the past 10 years or so, my focus has been on aphasia disparities and what that means. That there's some evidence out there that there are differences by racial ethnic background, that there's probably sex and gender differences, and probably outcomes are worse among individuals from lower socioeconomic status. So I'm not going to spend time here. I'm going to assume that this group understands what the condition that we're talking about, and that more than 200,000 Americans acquire this disorder each year. So if we think that the stroke rate is 795, which has been pretty stable for the last 20 years, and we've actually seen some decline, a fourth to maybe a third of that group all have persisting aphasia at discharge. And there's some estimates that suggest that there may be 2.5 million people in the US who are still experiencing aphasia. And most of the data suggests that might be an underestimate. So there's a large group of individuals who are experiencing aphasia. And even in 2023, there's like a lack of let's say worldwide understanding of the condition and what it means for people with aphasia. This is just to highlight a couple of the studies that I've been involved in, but to show that the issue of racial ethnic disparities in aphasia outcomes is not new, and it did not start with my work. That you can go back as far as 1997, that some of the work that Terry Wirtz was doing in the VA showed that there are differences in racial differences in aphasia outcomes. And the question consistently became, is this a real difference? Is this a manifestation of measurement, which is probably in play? Is this an issue of just a younger cohort? Folks have asked about genetics, people have asked about diet and nutrition, but regardless of the hypotheses, these differences tend to be very consistent. And they tend to also align with the fact that people of color tend to be about a decade younger when they have stroke and experience aphasia. In most data sets, that's kind of how the numbers emerge. And so the issues and impact are very different. So if a person is having aphasia in their late 40s and early 50s, which aligns with moving into peak earning years, that's very different than an individual who is having a stroke and aphasia in their 60s and 70s. So the kind of the dynamics of race and age and aphasia are in play and potentially having some differential impacts. So in the groups that I've worked with, and I spend a lot of time with economists and looking at large data sets and looking at access, resource utilization, the first thought would be, okay, if there are differences that align by race, let's look at service utilization, that there must be a difference in what people are receiving, and that's probably driving these outcomes. That seems to be a very simple solution. And what you find is that that's not the case. That when you look in acute care settings, when you look at overall healthcare utilization, Blacks, when you look at national data set, tend to have longer acute care stays. They tend to have greater costs, and they're utilizing greater resources in the acute care settings. And when we arrived at this first conclusion, that didn't seem to make a lot of sense until we started looking at the broader stroke literature and other disabling conditions. And this trend is very consistent, that there tends to be greater use among people of color in the acute care settings. And then something happens when they transition into the more higher intensity treatment settings. And we've wondered how that translates into what we see in aphasia when we know that high intensity treatments are vital to the overall outcomes. So we evaluated this in HCUP data in the state of North Carolina. We evaluated the same types of, or utilized the same type of data to look at North and South Carolina on just specifically speech and language pathology utilization in the acute care setting. And we found the exact same pattern, that there's this differential use with the individuals with the worst outcomes actually receiving greater services in the acute care setting. So the next step has to be that we have to look beyond what's happening in acute care settings. And we have a grant right now of where we're following folks using Medicare data from the time of admission through 1 year to look at the types of care that they receive and the different types of transitions. A lot of that thought came from, I think, a really good study that was published in, I think this 2017, that concluded that there are no racial difference in rehabilitation therapy across post-acute care settings. So that was going to be our next step to evaluate speech pathology utilization in the post-acute care setting to see if that trend changed. And so this beautiful paper came out, and we were able to gather some insights. But one of the first things that we realized is that the data was the availability of data related to speech language therapy was far more limited than physical therapy. So the primary conclusions drawn were based on physical therapy. But you can see when you look at issues of utilization in the post-acute care setting, there are very little differences across racial ethnic groups. However, when you started to look closely at the different settings, that trend held up until, if you look at the bottom right, until patients with stroke started to move into these more higher intensity settings when they moved into home health or outpatient setting. And although the final three rows did not reach statistical significance, that you can see that the trend in terms of intensity reversed, that you look at all the columns, whites are receiving higher intensity, lower intensity, until you get to these more outpatient settings. And then you see that whites start to receive higher intensity treatments relatives to Blacks. The other issue is this idea of transitions, in that they were able to evaluate the total number of transition. And this data is only for physical therapy. So I'm taking some liberty to help us think about this and generate some questions for speech language pathology. So the transitions reflected the number of settings where PT was received in the first year, and the median number of transitions was 2. The number of transitions among Blacks was more common. So they're moving between settings more frequently than whites, which may indicate some issue with not only intensity of treatment, but quality of treatment, and that we know that when you're bouncing in and out of different systems, that systems have philosophical differences in how they manage rehabilitation. So, for example, the University of Florida philosophy may not be the same as the University of South Carolina, even though we operate under clinical practice guidelines. It's systems, and then it's also, we have to think about providers. So if I have aphasia, I want an aphasiologist. I want a person who spends every day working with people with aphasia. But there are many people with aphasia that get a person who's a generalist, that they work with people with aphasia, and they work with children, and they work with a wide range of conditions. And so this idea of experience transition translates into quality, and ultimately quality drives some of the outcomes that we see. So this question of what drives the outcomes becomes a very complicated one. Now, I want to pivot just a bit and talk about what I want to focus on for the next 15 or 20 minutes, which are the social determinants of health. And these are the conditions in which people learn, work, play, and it affects their quality of life. I believe the key thing that is missing in aphasia research is a clear understanding that people don't arrive at a stroke at the same time or in the same way. Yes, there's high variability across all individuals who have strokes, but there are some differences in how where you live and these other social determinants influence things like early brain language development, risk factor development, and then brain changes over the lifespan. And we tend to take like an index or a metric of comorbid conditions, and that may not be enough, that it's really the duration of these conditions, and that there's evidence that conditions like hypertension, diabetes, they start in adolescence in Black children, but not in white children. So when two people, say a Black adult and a white adult, arrive at a stroke at 60, they're arriving with very different vascular profiles. They're arriving at very different beliefs and attitudes. So their upstream and downstream systems factors, influences can be very different. And then when we start to look in stroke research and aphasia, not only are they arriving at with different exposures, but they're also arriving almost a decade difference in age. And so it's not clear how some of these factors translate into any of the disparities in aphasia outcomes that we see. There's another process that's probably getting a lot more traction, is this weathering process. And it's kind of these accumulative physiological stress effects that it's been linked to people of color. It's starting to be linked to people from lower socioeconomic backgrounds, and that how that process is impacting people when they have a stroke, and then the ultimate outcome. So if we believe in this weathering process that may be affecting the vascular system in some way, it may have some differential effect on the aphasia outcomes that we see. The final piece that I want to add, and this is a theoretical paper, but I think it offers some pretty tremendous insights in some of the racial disparities and outcomes that we see. And in this paper, they argue that most stroke survivors, they have this major decline in level of disability, and then while they're in high quality systems during this acute and early recovery period, that their trajectories are fairly similar. But what happens, it is unclear what happens when they go to the community living period. That yes, even if they're receiving the same type of outpatient care, it's hard for us to really think about and measure what is going on in the home and what is going on in the community. So it's not simply the things, the services that we're providing, but it's the services that we're providing in the context of these communities where they live, which may or may not support the recovery, the recovery process. Things like sidewalks and being able to exercise, parks, having access to good nutrition. Here in Gainesville, it's very interesting that there are pharmacies and grocery stores on every block until you go to the east side of town, and it's essentially a food desert. You can't buy food. There's no pharmacies of probably half of the city. And a lot of cities are organized like that, and that's not conducive to facilitating the best outcome. So we're not blaming the people with aphasia. That's just the context and the situation that they're in, but that may facilitate or create barriers for the recovery process. So our next step was to try to understand, can we tap into understanding social determinants and community living period, even though we collect very bare bones information. We do collect things like the person's job and their income and maybe what they're retired from, but we don't get into understanding some of the family structure. We collect data on social support, whether or not a person has a spouse. We know that those translate into better outcomes, but it's harder to understand who's in the home and how that might translate into communication or better communication, or how it might translate or be impacted by the communities in which people reside. So this is a study that we published a couple of months ago, and I have to give the economist Molly Jacobs a lot of credit on how to conceptualize this, because this is not the kind of study that I would have been able to complete by my own data collection, or even using standard data sets to address some of the issues of social determinants. The focus of the study was on just simple naming. And we know that naming can be linked to impairment in aphasia. And it's also utilized as a very consistent target for measuring improvement. But explanations of naming improvement have just focused on neurological changes, and we just wondered, are the social determinants in play? So if we look at naming in some of our research and consider this community living period, are there other factors that might be in play? So our aim was to examine a subset of social determinants and how they might impact naming ability in a diverse cohort. So my economist friend said, this is what we can do. If you can find an aphasia data set, then what we can do is we can create an integrated data set by mapping it onto national survey data using this propensity score matching algorithm. And this is the gist of what it looked like. So she took data from the MAPS medical expenditure panel and created this data integration with this MAP data so that we could evaluate the impact of the social determinants on these naming outcomes. And so that she utilized a 3-to-1 for every MAP individual. There were 3 MAPS respondents, so that we could get a consistent profile of the social determinants and what that would look like in individuals with aphasia, and then explore that issue on their naming ability. So here are some of the key variables that we use: time post-onset, age, aphasia type, sex, race, region of residence, marital status, family size, and family income. The economists, they're always very interested in understanding family size and income and how that impacts health-related outcomes, because there's substantial literature that says who's in the home and the types of resources that are available probably drive a lot of the outcomes. So here's our general modeling strategy, and then our outcome variable was related to BNT percentile scores. Here are the key findings. Individuals, once you created this profile of individuals with aphasia and mapped it onto social determinants, those individuals with higher income and larger family size tended to very consistently had higher BNT scores. Those individuals who were older or who were Black and even higher educated, and I'll talk about education in just a bit, because it doesn't seem to be as clear, but these individuals tend to have lower percentile scores. The one that's still not entirely clear to me is why higher education is maybe tied to lower scores. And there are a couple of other studies that suggest that it's really that we don't do a good job of stratifying educational levels, and that the samples are maybe too crowded, and we're not getting to this issue of quality of education. So it may be that's just a poor predictor of outcomes. But this issue of higher income, we do believe, is tied to greater resources. So it's not just about the money, but people who have more money tend to be tied to greater sets of resources that can help in health-related conditions. And it's possible that that's what we're seeing here in aphasia. Larger family size could be that it's simply there are more people in the home that's stimulating the communication process more. There's a lot more work to be done in that area, but these findings tend to align with some of the current literature. And then age and race have been very consistent predictors of more negative outcomes. So here's kind of where we landed, is that we think that these social determinants, they have to be considered in aphasia outcomes. And the question that I get very consistently is, what data should we be collecting? And I don't know that I have kind of a final answer, but we need more than understanding a person's income, but we need to understand the resources that they're connected to. So I live in Gainesville, Florida. I have no family in Florida, but I've lived here before and I have a great network. So I have access to a lot of resources in ways that people who may have grown up in Florida may not. So I think this issue has to be explored, and how upward financial mobility and personal life experiences are linked to things like education and occupation, and then ultimately health-related outcomes. And we just think that family size is linked to greater opportunities for communication and addressing the naming skills in the recovery process. This is not a it's a complex puzzle, and this is a figure from a paper that I published with colleagues at MUSC in 2019, and it highlights this issues of congenital stroke, and I think it also ties to aphasia, that there are barriers and facilitators, that even when we offer first-rate care, that people with aphasia, stroke survivors, they have barriers and facilitators that are in their homes, that we may be a barrier or a facilitator, and then their community also has a set of barriers and facilitators. And as you look through that list, especially on the caregivers, you can see things like the personal characteristics of the individual, the caregiver support, coordinated medical care, and then community support. Also in terms of community, things like what is their post-stroke environment, and then also their transportation. So I believe when we're measuring aphasia outcomes, we're measuring more than just impairment and functional communication, but we're measuring those in the context of the environments in which these individuals live. So these findings, they don't argue against severity and location and neurological. We know that those are the drivers of outcomes, but it does highlight the idea that maybe we need to try to figure out what's happening in these post-discharge settings that might be also influencing these outcomes. Now, with just a few more minutes, I want to move into our second study. This is unpublished data. The approach was exactly the same, but I was interested in understanding more than just naming. So our first study showed that, hey, the social determinants probably matter, but what does that mean if we can tie this to more traditional measures like the WAB-R AQ? Will we see the same pattern? And so to answer this question, we took a very similar approach, but with totally different data sets. So for this second study, we utilized data from the AphasiaBank and the National Health Interview Survey. We utilized the same data integration approach so that we could evaluate the impact of social determinants on this simulated sample. Our second study, and I may have omitted this, but in our first study, we ended up with, in our simulated sample, N of 165. And this second study, it was an N of almost 500 using the same algorithms and approaches. And interestingly, although we utilized two very different data sets, family size and access to resources such as higher income was associated with better performance. Also, the uninsured and those with condition-related care visits. So speech pathology services would be a condition-related care visit, or a college degree were associated with higher language performance. So we didn't have the inverse relationship with education and language performance in this much larger sample. So my first question was, how is it that the uninsured would have better outcomes? And the economist said, well, the uninsured, they have other options beyond what you see in private insurance. They can go to Medicaid, they can quickly move to Medicare disability even at younger ages, and it allows them greater access to rehabilitation services beyond what we might see in private insurance that might be limited to 10 or 15 visits. So there's actually some advantage to not having insurance and then taking the Medicaid and Medicare disability route. So although a very different sample, the conclusions were very similar, that education, quality of education, it matters. It's not just being educated, because in the US, there are many folks that have high school diplomas that can't read. So it's got to be the quality of education. I do believe income and connectedness to resources, it matters, family size matters. And then we've got to really think about why there are these negative racial ethnic differences. And I don't think it's enough to just say it's access to care. When we look at the stroke literature, early evidence-based approaches tend to be different. The recovery environments seem to be different. And we've got to integrate this issue of the weathering process. If we believe that impacts some of the outcomes, then we have to not only collect the number of comorbid conditions, but the length of time that individuals have had these comorbid conditions, so that maybe there are some indices that can be created to help us understand the longer term impact. Ultimately, I think this is kind of where we are. This is a recent paper that we've got to move away from just racial comparisons and income comparisons, but we have to get into this different level of modeling based on intersectionality. And it allows you to think about the multiple dimensions of health and disease and how that translates over time, because I believe that some of these differences occur on the front end, in that the underlying cause of aphasia, that different population groups arrive there in very different ways, and then we offer excellent treatment, and then they go to very different environments. So the intersection allows you to evaluate the context in which they're experiencing the condition. Many of you have seen the socioecological model. This is a way to really think through the multiple levels of determinants that might be driving the aphasia outcomes. But ultimately, we've got to really kind of rethink how we organize research, that we've got to think about different approaches. I believe we have to align with other disciplines to help us analyze our data beyond traditional approaches that we use. And we need to be cautious about some of the conclusions that we draw, because when you look at if you go to an insurance company's research and development page, which seems odd to me that they would have an R&D page, but oftentimes there you will find our research, and you will find their interpretation of our research without our clinical expertise. So I believe we have to rethink some aspects of our approaches, so that we're generating outcomes data that considers a wide range of factors among very heterogeneous population. So this is where I'm going to end. I do think the social determinants, they matter. I think they matter in any health-related outcomes. I believe they matter in aphasia. I think as our research continues to evolve, we've got to understand better how these social determinants are in play, and how an individual arrives with a diagnosis of stroke and aphasia. I think the new America, the more diverse that we've been talking about my entire lifetime, it's here. It's a very diverse, and so our approaches also have to consider how our research translates to this population groups. I also think diversity in the clinical workforce and research teams is also critical to think through not just what our participants and clients are saying, but the part that they're not saying that potentially impacts some of the outcomes that we see. So I think that's a good stopping point. Every time I give these talks, I leave with far more questions, I believe, than answers that I'm trying to provide. I think this is just an emerging field. There's a lot of work to be done, and we're up to the task. So these are my works and cited, and I will stop there.
Thank you so much, Dr. Ellis. I hope you can see us. Most people are here in the back of the room, so I hope you.
That's where I would be if I were in the room too.
We have more than you see on the screen. Thank you so much. That was a wonderful talk, and lots of food for thought. So we have some questions online already, but I want to give it to opportunity for people in our own room first to ask questions if they have them. Please let me know if you can't hear, because Charles, because then I can repeat the question.
Okay.
Heather Bonilla has a question.
Hi, Charles. So my question would be, this is awesome presentation, great information. I think probably like you, it leaves me wanting action steps. And so if we could do one or two things to make this better as interventions, what are you seeing from the data and from all of your vast experience we should be doing or could put into place while we still have this time when we're trying to really figure out what's going on, but what can we do now to make things better?
Yeah, I think there's a couple of things. The first is we have to train clinicians, especially SLPs, but other medical professions to collect more comprehensive data. So when a physician sits down with a patient of any condition, they're looking at multiple systems. I'm not suggesting that we need to do that, but we have to look more beyond just what is the person's education score, what is their aphasia type, and what is their insurance. That we need to spend more time really understanding their pathway. And we need to understand disease duration, and there are some indices that are moving us in that direction. In terms of if we're really going to address this issue of disparity gap, then we've got to understand who's getting what and at what time. So I think there's a couple of studies. We have one. There's some others that are following these pathways to see, is there equitable care. I think the other piece that's missing is we don't spend a lot of time understanding beliefs and attitudes of people. We just assume that because we're trained in this area and we're giving our best, that people are going to want that, and they don't. People want what they want, and we're not always clear on what they want. When I lived in Charleston, I was shocked with some of what I learned, that people won't come to MUSC, they go to this hospital for this. There's a long history there, but I'm finding that kind of history exists in a lot of places. That this beliefs and attitude divide, and I don't want to blame I'm not to blame the patient, but we have to consider that. Also, I think on the other end, as we're designing treatments, we have to understand more cost benefit and how that differs across different population groups. It doesn't matter if I develop a study and I show 10 points in a WAB-R AQ or 10 points in Boston naming, if it costs $10,000 to get those 10 points, as opposed to could we do that with $2,000. So I think those are the things I think, just kind of reorienting ourselves and thinking about asking more detailed questions of what led to the condition that caused aphasia. And I think we need to align that with more the advancements in imaging. Imaging it changes so rapidly, and we know so much more about the brain every 2 or 3 years, but we don't necessarily link that to what we know about patient characteristics and health and disease. So that was a long-winded 2 or 3 things that I think we could do. So when I teach aphasia, I talk about understanding the disease condition and how the person arrived there and what that might mean going forward.
Thank you so much. Are there other questions from our own room? Nope, hearing none. We do have questions online. Amy Dietz says, thank you for a fantastic talk. I'm not surprised by family size and the idea of supporting or facilitating naming or communication. Can you clarify or confirm that you are referring to local family, or can this family be anywhere? And perhaps they're talking via Zoom or FaceTime.
Yeah, it's family in the home. So national surveys, when national surveys are collected, it's the number of people in the home. And I'm glad you raised that question, because I haven't even thought about the other family connections. Economists, when you talk to them, they're very interested in who's in the home, who's making money in the home, and how does that impact the health of everyone in the home. So when we talk about family size, it's individuals in the home.
Great, thanks. I had a question that I typed at the beginning of your presentation. So not to take away from your message that we shouldn't be focusing only on things like insurance But I did have a question about a potential factor. So perhaps with the initial speed of intervention being so important in present-day stroke care, is it possible that time to hospital is an important factor? And do we have any data on that? So, and a factor that would predict more severe negative stroke outcomes, particularly in underrepresented or groups or low SCS groups, which might then translate to higher costs and more use of care.
Yeah, so there is quite a bit of data related to time to treatment, and actually what's happening even when time to treatment is equivalent. The utilization of evidence-based care is very different between men and women and blacks and whites. That's been very much established. Part of it with people of color has to do with greater likelihood of hemorrhagic stroke. A lot of the literature seems to suggest that. So there can be delays in the offering of evidence-based care. I think the other part of this issue of access to care is the urban versus rural dynamic and real access versus perceived access. So you can live 2 miles from a major medical center and not have perceived access. So when there are issues or concerns about access, that translates into delays in seeking treatment. So there's no one to blame about delays in seeking care. I think there are some issues in equity of evidence-based care, things like TPA, but there are also differences in how people rationalize symptomology and how quick they are to act on them. One of the things that we saw during COVID is that there seemed to be a decline in stroke. And as people have started to look at that closer, most believe there wasn't really a decline. It's just that people were less likely to go into an ER and risk getting COVID, even if they knew that they needed treatment for stroke. So it's a complex balancing between what we're doing or medical management across different population groups, and then how different population groups respond and choose to access.
Great, thank you. I have a comment, compliments from M. Goodman. That's the name I see on my Zoom. Thanks for a great presentation, critical research, and an important, huge stride in thinking for all of CSD. Huge kudos to you and your team and your co-researchers on providing this perspective in the open. And I did have another question, perhaps related to the issue of trust. What are your thoughts about the potential influence of the match or mismatch in race, ethnicity between stroke survivors and their care providers?
Yeah, that's a really tough one. So the literature generally says when there's lack of race concordance between the patient and provider, that trust is low. And even once you control for that, when there's lack of race concordance between the patient and provider, satisfaction is always different. So the real, what we know most about is people being satisfied with providers, and when they're not satisfied, what are their behaviors? And oftentimes the behaviors are, I don't trust this person, or I'm not satisfied with them, so I'm going to take these 2 pills, but I'm not going to take that one because he didn't really explain, or she didn't really explain why I needed to take that from a preventive standpoint. So there's really strong evidence in medicine and nursing about the issue of race concordance and trust and satisfaction, and that does seem to translate into some of the outcomes. I think we need to understand that issue for aphasia research, because when you're trying to recruit people of color, the PI is not the face of the study. They're not. The face of the study is the individual who's recruiting and is interacting with the people with aphasia. If there's not race concordance there and that person doesn't understand that this is even an issue, then PIs are going to have difficulty recruiting people of color. And that's just, unfortunately, a fact. I've seen it over and over and over. The PI is not the face of the study when it comes to the people that they're recruiting. So so there's things that we can do on our end and our investigations to help with this issue as well.
If I may, it's a complex issue to solve, though, right? Because even if, you know, on the whole, obviously we need to have more diversity in the clinical, in the population of care providers. On the other hand, I'm not sure one would want to fix this issue by saying, well, sir, you've just had a stroke, you look like this, so now you need to be matched with a particular speech pathologist just because of race or ethnicity, right? I don't think that would be a desirable way to act.
I think there's different beliefs about that. I think that's probably where I will land. There are groups that are saying, no, that's exactly what needs to happen. I don't necessarily think that's what needs to happen, but I think we are falling short on things like things like cultural diversity training. I've never seen a study that shows how these trainings can translate into a person's behavior, that the outcomes of cultural competence training is always, did you take the training or you didn't? And no one has moved forward to see how that governs behavior. So I think we're a long way from understanding that issue. I think there are some groups that think that you should make every effort. I don't know if raw numbers can accomplish that. I don't know if we have the raw numbers to accomplish that. I think what we need is just people who are thoughtful, regardless of their race, so that when that first interaction occurs, that it's more positive than negative. It's on the provider to break down the walls and make the client or research petition. It's the patient can't close the gap. It's just like students and faculty. We have to close the gap.
Thank you so much. I think that is the perfect note on which to end today's presentation.
Yep.
We have more questions online. Thank you, Dr. Ellis.
All right. Thank you so much.
And thank you, audience, abroad, at home, and in the room. And we'll see you in 2 weeks' time.